to our discussion this morning on the sniffing accountant for Psyfeld. I want to welcome all the students that are joining us and open it up quickly. With regard to the episode in question, the sniffing accountant, any observations? Who would you like to talk about? I'm going to ask the third-year clerks to please enable your video. Any particular character or character's behavior that caught your eye last night? Oh, we have technical difficulty. I'm going to pause this. I'm going to ask. Oh, you can? Yeah. I didn't do anything different. That's funny. All right. So welcome. Sorry about the delay. Any character or character's behavior you'd like to discuss first? Anything is on the table. All right. So welcome. Sorry about the delay. Any character or character's behavior you'd like to discuss first? Interesting that we have a delay too. Could you hear me now? All right, let me I'm going to log off and log back on. I'm getting a weird feedback. I'm hearing myself talk from a minute ago. Let's see if this works. And Zoom cooperates this morning. We'll join. All right. How about now? Can you hear me now? Yes, I can hear you. Ah, much better. For some reason, that was a weird delay. All right, so we'll try it one more time from my end. Any interesting behavior you'd like to discuss?
I think from the forefront, the accountant's potential substance use disorder.
Okay. Now, other than, and we'll talk about his behavior in a second. His actual physiologic sniffing. Other than that, behaviorally, can you describe the accountant?
I would say that he's definitely showing some potential drug using behavior of going to the bathroom constantly. And then he shows, I guess, impulsivity with his purchases. And then at the end, he shows he's not good with managing his money as well.
Right. All right. So we do have some behavioral characteristics with regard to identifying, let's just say, behavior that may be clinically significant that is outside of a culturally sanctioned norm. And then if you add on the physiologic observation with regard to his sniffing, I think this all comes together. There's a couple of things here I want to make sure we cover. Number one, a reminder that these substances of abuse that we've been discussing have both psychological / behavioral as well as physiologic aspects of their acute intoxication phase. And for the most likely drug here, cocaine / stimulant, we have to keep that in mind. So at-risk behavior, impulsive behavior, but then also physiologic characteristics as well. It's the physiologic characteristic that is likely to differentiate this condition on a shelf exam for a student or any exam for a student from an acute MI. Now, in this case, in the sniffing accountant, the Seinfeld episode we're discussing this morning, there is no evidence that the accountant is having an acute myocardial infarction. However, on an exam, it is very likely to be such a case. So on a psychiatry shelf, really any test for that matter, When an individual presents with what looks like an acute MI, we have to think cocaine use disorder or cocaine intoxication until proven otherwise, especially if it is a younger patient. Now, he's in the demographic where we should be concerned that this is, in fact, an acute MI. This is the result of systemic atherosclerotic disease. But on an exam, even if age is not provided, there are two things that I want you to focus on with regard to a pertinent positive as well as a pertinent negative. The pertinent negative is critical here, and that is the clinical vignette is likely to give you zero evidence of acute myocardial ischemia, right? So if they provide you an EKG, there should be no ST wave elevations. On the other hand, if they provide you serum markers, there should be no elevations in troponin or similar markers. So the absence of that now strongly points you toward either a panic attack or cocaine use disorder. In this case, we're going to rule in for a panic attack. Panic attack is pretty much synonymous with cocaine intoxication. One, of course, is induced by the exogenous substance. The other is endogenous. The etiology is endogenous, if you will. So the two are, again, clinically indistinguishable: panic attack and acute cocaine intoxication. Cocaine intoxication may actually induce a panic attack, or it may induce an MI. So in either case, the test taker, the clinician, is going to have to differentiate between the two. With regard to a panic attack that is induced by the physiologic effect of this substance, we look for those other signs, and certainly more times than not, 80+% of the time, the focus will be on the nose. So there'll be some evidence of nasal septal perforation or consistent or recurrent nosebleeds. All right, so somebody comes in clinically, they present with a panic attack. They present with increased sympathetic tone. First question: is there any evidence of acute myocardial ischemia? If the answer is no, the differential largely is going to be a panic attack versus that which is induced by the direct and physiologic effect of the substance, cocaine. The latter, a cocaine-induced or stimulant-induced anxiety disorder / panic, will be ruled in if there's any evidence of nasal septal erosion or perforation. Without that evidence, panic attack, most likely diagnosis on your shelf exam or a midterm exam. On the other hand, if it's an acute MI, that can also be induced by cocaine, or it can be due to systemic atherosclerotic disease. And there's again, any evidence of cocaine certainly would support that as the etiology. However, in the absence of that, we look at demographics. All right, an acute MI, a heart attack in a young person, is due to the direct physiologic effect of a substance until proven otherwise. All right, so I wanted to make sure I broke that down for you, since many of the students are about 1 week away. Actually, two sets of students are about 1 week away from an exam. Before I go on, any thoughts, any questions pertaining to cocaine and its inducing an acute myocardial infarction? Good. All right, we're okay. All right. So, otherwise, anything else with the accountant beyond rule out cocaine use disorder, rule out cocaine intoxication? Any other characters you want to discuss here?
Well, I would say with the accountant, one thing I noticed was it did seem a little bit odd that he was like going to a bar to drink alone afterward. That would maybe hint at possible alcohol use disorder. But as far as other people, I was looking at Elaine during this.
Go ahead. What did you observe in Elaine?
Well, they
quite a bit of pushing away, I guess maybe as like defense mechanism.
Yeah. Okay. So with regard to your first comment, I think the clinical pearl to take away from someone who we believe there is an established stimulant use disorder is that the clinician should never take a breath to pat themselves on the back when they screen for and then identify a substance use disorder, because and this is more DSM-4 terminology. The individual may actually have polysubstance dependence. Here we'll just call it, per the DSM-5, polysubstance use. So screening for other drugs and screening for alcohol certainly is still on the table and part of the complete social history. For alcohol purposes, please administer the CAGE questions. Any guesses as to what your thresholds should be that would hallmark a positive screening test? How many questions out of the 4 will a person endorse for you to consider it a positive screen?
I believe it's 2 questions out of the 4.
Yep. So in the literature, it has been arbitrarily agreed upon that 2 out of the 4 is a positive test. And the reason why the medical literature does this is so there's consistency and reliability across different studies. With the threshold being 2, there is about an 80% sensitivity as well as an 80% specificity of the CAGE screen. In clinical practice, it's of great benefit to allow 1 out of the 4 to be a positive screen, because when you do that, the sensitivity of the screening test goes up to the mid-90s, albeit at the cost of several more false positives. Now, those false positives will be rooted out because you are going to ask more questions, and you're going to, for those false positives, you're going to find out that there's nothing here. So the detriment of using 1 out of 4 is only that the clinician, on occasion, will quote unquote waste their time in having discovered that their positive screen is actually a false positive. But that's not a true waste of time, especially when you understand that you've greatly increased the sensitivity of your screening test. So literature, 2 out of 4, 80 and 80, but 1 out of 4 in clinical practice to allow for a sensitivity, which is critical for the screen for any screening test, in the mid-90s. Right, so 1 out of 4. If you do use 1 out of 4, and again, I strongly recommend this from a clinical perspective, the next set of questions to consider are twofold. Number 1, how often do you drink? And when you drink, what is your average amount per drinking episode? Those come directly from evidence-based studies with regard to a secondary screen. However, if you are comfortable, you can go right to the structured clinical interview, and you could review the signs and the symptoms, the actual DSM diagnostic criteria of, in this case, alcohol use disorder. So you can do either or. You can provide the structural interview, or you can provide a secondary screen, which, if positive, will then default to the structured interview. But in either case, you'll weed out false positives. What do you think is going on with Elaine? So we have collateral report that this is recurrent behavior, and it seems, since it affects interpersonal relationships, it's recurrent behavior that is clinically significant, right? So if that's the case, Elaine may present to a practitioner, to a psychiatrist, with this proverbial chief complaint. As you're formulating this, what are some things going through your mind? Why is this happening?
Could be like a past history of trauma or something.
Could be. We know very little about her history over 9 seasons. For those of you who are familiar with Seinfeld, Larry David does give us a little bit of history. Certainly not trauma, but that doesn't mean that there isn't any trauma in her history, of course. So that's certainly something that the clinician would need to investigate.
Going along with what Shelby said earlier regarding volatile relationships, maybe she could show borderline personality disorder or cluster B traits?
All right. So Elaine does, on occasion, demonstrate clinically significant cluster B traits. Again, for those playing along at home, cluster B comes from that second group of personality disorders, which does include borderline, but also includes narcissistic, histrionic, and antisocial personality disorders as well. So that certainly could be. But in either case, other than trauma, um, what what may have been that third variable? Maybe something that both contributed to her developing cluster B traits, if not a cluster B personality disorder, as evidenced by what you're actually observing here in this episode, which is a volatile relationship. Anybody here routinely or in the past watched the situational comedy? Do you know this character? I'm getting a bunch of no's. Um, Again, and for those else that are logged on, please feel free to unmute and contribute. Um, One of the things we understand about Elaine is that she has a very cold relationship, a very emotionally distant relationship with her father. There's, I think, one episode through the 9 seasons in which we're told she has a sister who lives in the Midwest, only because she's returning from a visit and Jerry needs to pick her up from the airport. And that's all the information. She's actually flying back to New York after having visited her sister. That's it. Elaine doesn't speak about her sister at all. We don't know if she has any other sibs. I don't think her mother is mentioned at all in any of the scripts through the 9 seasons, and her father does make a few appearances. And when he does, he is a main character. I mean, in as much as the plot or subplot of that particular episode revolves around him. He's a very strong character. And Elaine, in one of those episodes, refers to him as an alcoholic. So there is something going on here that Larry David hints at. Beyond that, now we begin to see what I think you may have referred to as trauma. She may have been traumatized growing up in as much as she was a child of an alcoholic parent. The rest of it we have to fill in through actual interview with the character. But that much is provided by the writer-producer. This...
Knowing her history, I was thinking like abandonment as something in her history, but I guess you might be able to consider this like emotional abandonment, given like the distance there.
Yeah, and we don't know if he's stuck at home either, though. I mean, so it may be more than emotional. To your point, yeah. This is object relations theory. This is the observation that Elaine's current relationships, current intimate relationships, reflect her primary relationship, which, of course, per Freud, would go back to the father, right? And go back to Elaine maybe when she's about 5 years old, when she identified her father as being different than her, right? Discovering that he's a man, not just dad, right? So that's merging Freudian theory with object relations, and certainly could reflect in her adult relationships, which are impaired. They are. This is not the only episode in which Elaine struggles, and again, her social support actually identifies that. This is a recurrent pattern of behavior.
Yeah, I was also thinking that I don't know if this is the perfect display of splitting, but like in her interaction with the guy when she first walks in, she's like, "Oh my God, you're perfect," because he's made dinner and he's cleaned the house and he took messages for her. And then within like a minute, she was so angry about like the exclamation mark and like what kind of a person wouldn't put an exclamation mark. So it seemed, very all or nothing. But at the same time, it also seemed like she was looking for a reason not to like him. So I don't know if it's classic.
Yeah, well, again, to the extent that she may end up in your office and then therefore perhaps in therapy, that is absolutely something to investigate. This the idealization, devaluation that results from splitting. People are either all good or all bad. There is no capacity to understand that everyone, as all people, actually have both good and bad attributes. So that could be part of it. Mm-hmm. Any other observations about Elaine before we move on to another character?
I think regarding her perceived obsession with exclamation points, I felt like she didn't believe there was anything wrong with her obsession or her use of exclamation points. So I thought it was obsessive compulsive personality disorder, perhaps, rather than OCD.
Well, this one's tricky, and this unfortunately is very poorly reflected on exams, and perhaps more importantly, exam review tests. We have to be very careful with regard to looking at obsessive compulsive disorder versus obsessive compulsive personality. Obsessive compulsive disorder is really straightforward. Now, in clinical practice, there's nothing easy about this disorder, not from the clinician's perspective, and certainly not from the patient's. But as far as exam taking purposes, obsessive compulsive disorder is simply an individual who is experiencing clinically significant obsessions and or compulsions, right? Obsessions, intrusive thoughts that in the case of the disorder will be impairing functioning. Compulsions are ritualistic behaviors that are thought to undo or revert back those things that are causing the obsessions, right? So if I don't wash my hands, I won't alleviate my anxiety. And that's it, okay? That is it. That's all you have to know for choosing OCD as the single best answer on an exam. Obsessive compulsive personality is a little different. And unlike OCD, where if you forget what you're really looking for, you need only look at the title to remind you, because the title, obsessive compulsive disorder, literally contains the DSM criteria: obsessions, compulsions. The opposite is true for OCPD. In obsessive compulsive personality, the definition doesn't contain the word obsession. The definition does not contain the word compulsion. The obsessive compulsive personality is a type A personality. It's the individual who is a micromanager. They have an attention to detail. They are a perfectionist. It's everything you think of when you think of the type A personality. So, right from this onset, whether it's egosyntonic or dystonic is rather irrelevant with regard to making the diagnosis, because the DSM criteria really could not be any different. If you think Elaine is having her behavior influenced and adversely influenced by obsessions and or compulsions, we're dealing with OCD. If, on the other hand, you think her clinical significance is due to the type A personality, individuals who are stubborn, rigid, frugal, micromanager, perfectionist, then you're dealing with the obsessive compulsive personality disorder. And from there, we can talk about ego dystonic versus syntonic, etc. So, from that observation, do you think Elaine is struggling with OCD or OCPD?
Now that you mentioned egosyntonic versus ego-dystonic can come later, I think it's more consistent with OCD. I wouldn't say, I don't know Elaine's character too well, but from what I know, I don't think she is type A personality per se. So I think it was, at least based on just this episode, I think it was just a show of obsession, and an obsession that was really with a compulsion of the usage of exclamation points.
Yeah. I think her character in this episode is significantly influenced by intrusive thoughts pertaining to the exclamation point. And if clinically significant, then I think OCD is going to be high in her differential. And also in this episode, it's worth mentioning that I don't see her as perfectionistic. I don't see her as needing to be in control like the type A personality must be in control. So I don't think the obsessive compulsive personality is in my differential here. And I'm going to cheat. With regard to all the other episodes from this season, as well as the other 8 seasons, Elaine really never gives off the idea of having the type A personality. Jerry Seinfeld, the character, totally different, but not Elaine.
That's interesting. I read that situation a bit differently. Like I don't know if I would say that she was getting any relief from the use of the exclamation marks. It seemed to me that the exclamation marks, because when she was writing all the exclamation marks in that article, it was an edit of the boyfriend, or now I guess ex boyfriend's article, so it seemed more like passive aggressive behavior, something that I would think of more with like a cluster B, like borderline type thing.
And again, she does have other characteristics of borderline that we previously discussed as well. So that's not out of the realm of possibility either. If we're going to make, or if we're going to consider making the diagnosis of OCD, again, for test taking purposes, remind yourself the individual does not need both obsessions and compulsions. They need one or the other. They could have both, but only one is required to actually make the diagnosis. So if you have somebody who presents on the exam who is obsessed, who actually has intrusive thoughts about, in this case, exclamation points, do not let the absence of compulsions lead you away from choosing obsessive compulsive disorder as your single best answer.
Yeah, I guess for me, it just didn't seem like it would be like a regular obsession. It just seemed like something that she was latching on to, and then kind of knew that she was being a little bit ridiculous, but then had to defend herself by like overdoing it on the exclamation marks to like kind of claim, no, I really do care about this. I wasn't just like trying to pick a fight over nothing.
And to support your suspicion, if Elaine is a patient sitting in front of you, what question will you now ask her?
Well, I guess I would want to know her history with this particular issue of like, is this something that you have been regularly thinking about before this incident? And also I would want to know if there were other things that she found that, she couldn't stop thinking about that were untrue.
That's it. That's exactly right. And that's going to give you your answer. That's going to give us the answer as to whether or not what we're observing is in fact part of OCD. If these are true obsessions, we're gonna inquire about whether she actually has intrusive thoughts pertaining to things beyond exclamation points. Because if she says yes, I think that'll, if not clinch it, that'll certainly support OCD in the differential diagnosis, no doubt. Now, if she says no, it's still a little tricky because individuals may have OCD diagnosed as a result of having one type of obsession. So we're not out of the woods yet, but you're exactly right here. This is a question for our patient. Any other characters you'd like to discuss? We only have a couple minutes left. Anybody else strike your attention, strike you as interesting? George, Kramer, anything that you've seen in these characters that you want to discuss? No, we're good. All right, so we'll end it here. Thank you for joining us for this episode of the Sniffing Accountant and Psyfeld. I apologize for the technical difficulties at the beginning, and I will see you in about a half an hour or so for morning rounds. Take care, and we'll see you in a few.